personal note, I've known each of our speakers for over a dozen years each, and I admire so many of their qualities, but most is their genuine kindness for their patients, for their colleagues, and for the broader allergy community. So I just couldn't be happier to moderate this session. After all of their presentations, we'll have a roundtable discussion with this special guest moderator. So now I'd like to introduce our first speaker, Dr. Ian Myles. Dr. Myles obtained an MD from the University of Colorado in 2005. He completed internal medicine residency at The Ohio State University prior to beginning fellowship training in allergy and immunology at NIH. During fellowship, he investigated the mechanistic details of susceptibility to Staph aureus skin infections. In 2011, he became a commissioned officer in the U.S. Public Health Service Commission Corps, and he has supported several U.S. PHS missions from the Ebola virus vaccine trial in West Africa to congressional gold medal ceremonies at the U.S. Capitol. In 2013, he was awarded a position as an assistant clinical investigator in the NIAID transition program in clinical research. Dr. Myles received his MPH from GW in 2016. In 2018, Dr. Myles became the head of a newly formed epithelial therapeutics unit in the Laboratory of Clinical Immunology and Microbiology at NIAID to evaluate the efficacy and safety of a topical live bacterial treatment for atopic dermatitis. Dr. Myles' talk today is entitled Evaluating Air Pollution as a Driver of Atopic Dermatitis. Please join me in welcoming Dr. Ian Myles.
All right, thank you, Dr. Sharma, for the introduction. I don't think I've been referred to as esteemed before, so I have to tell my mom. All right, it's trying to mess with me. Okay. All right, thank you. So this, the hat that you see there is taken from the Eczema Expo, and so the hat was supposed to be a joke from the patients to warn people that like any little thing will set them off any kind of flare. So that's where we're taking this from. And they may have been right. So we work for the government, so no disclosures. Okay, so for most of us to know, this is true for pretty much all allergic diseases, but is definitely true for atopic derm. There's been this substantive rise in the incidence of the disease since right around 1970 or so. And to me, this kind of brings up an analogy that actually comes from social justice world, but it's called the groundwater approach. The concept is if you come across a lake and there's 1 or 2 dead fish floating in the water, it makes sense to kind of poke around at the fish and say what's wrong with them. But if 20% of the fish are dead in the water, you're going to know intrinsically not to get into the lake, particularly if those fish are the ones that are all near particular kinds of pollutants. So there's been this kind of fanaticism about looking for genetic predispositions in the allergy world, I think. But whatever went wrong with our children absolutely went wrong sometime around 1970 or so. So there's no greater explainer of the microbiome than Richard Scarry's Busy Town. You just show this to people and they intrinsically start to get it because you'd say, all right, well, we can categorize them in broad strokes in terms of the different kinds of organisms that might live there. We can get more and more detailed as our sequencing technology got better and better, all the way down to isolate level identification for lowly the worm and Huckle the cat here on an individual level. But really, as the field has continued to progress, we start to have conversations about their function. So what are those bacteria actually doing for you living there? Because if you really need a tow truck driver, you can't just go grab any pig off the street. We need to have those kind of functions. So on the skin, when you're looking at what does the microbiome do, for the most part, it's a lipid-centric kind of conversation. They produce or assist with protective skin lipids. So the bacteria we work on is Roseomonas mucosa. It'll actually produce ceramides for you. You've probably heard of those. They're in you go to the grocery store, you'll see some lotions that brag about having ceramides in it. There is actual evidence that that's supportive and protective. They're there to help water loss. Mike Otto's group demonstrated that Staph epidermidis actually, it doesn't make its own ceramides, but it helps the host make more of its intrinsic ceramides. Then there's some other ones. Staph conii can help with steroids, which we remember as a cholesterol derivative. So it's very kind of lipid-centric. There's been a lot of conversation about Staph aureus, and fair enough, right? Because it makes all these different kinds of things that will make eczema worse. However, this is very important. Staph is contagious and eczema is absolutely not. So whatever the underlying defect is, staph cannot take advantage of it. Otherwise, you'd be able to catch a flare or you'd be able to catch atopic derm. So staph is coming in as some kind of secondary infection or secondary problem and can't possibly be the primary cause. So if you start to ask, all right, what could be the primary cause? If you go through the literature to say the different types of environmental exposures that might matter, we can break them in. I break them into 4 basic categories. The first is living in an industrialized nation. So processed foods, not good for you. Antibiotics, statistically significant. Talk a lot about family history, but it really ends up being the mom. And that probably has a lot to do with the gut microbiome and vaginal delivery, although C-section doesn't really pan out as much as we'd like to think. Older siblings are protective. And moving to the United States or Europe from a non-industrialized country or a less industrialized country before you're 2 has a substantive increase of risk. If you can move after you're 6, you can move wherever you want and make absolutely no impact on your risk whatsoever. But before you're 2 matters. Inside the United States, there's an additional risk on top of that for living in an urbanized environment. And environmental science and population density tends to, this is the graph showing you the older siblings are protective. So you can see the number of siblings you have, your rate goes down, daycare, somewhat protective, and so forth. All right, when we talk about population density, you tend to think about car exhaust and all of these different products that come out of the back of the car. They're weakly associated, some positive, some not, but really highlights that if you're pregnant near a highway, that you have a much stronger risk than any of these individual components. It's hard because if they all come out of the back of the car exhaust, it's impossible to separate one from the other, but they're all going down since the 1970s, which is a good thing. So they're plummeting, even though the rates are of atopic derm are going up. They're not going down equally everywhere in every corner of America, but for the most part, they're going down. Dr. Maria Way out in San Francisco really kind of put the concept of wildfires, smoke on the map, that really big one they had a few years ago where the sky was orange. She can map people coming into the dermatology clinic. She could actually map Google searches as the flyers plumed out. People were Googling eczema as their PM started to increase. So wildfires is on the list. And then different things that you'd put into your homes that don't make a ton of sense initially. But the idea like tobacco smoke, that's what ETS is, that makes everything worse. Patients will naturally gravitate away from nylon, spandex, and polyester. But like, again, new flooring, furniture, and so forth before you're 2 greatly increases your risk. After 4, go ahead and remodel to your heart's content. It's not going to matter. But, wallpaper, glue, and so forth. Okay, so when we came to this, you all recognized the distribution of atopic derm. And when we contrasted it with the Human Microbiome Project that happened before I came along, what I've done here is I've colored in where you find the gram-negative organisms. And so I found that to be an intriguing overlap, not a perfect one. And so the point is that when a patient is under excellent control, so they don't have any rash or itch, people have looked by mass spec and they continue to have a phospholipid-related defect at baseline. There's no cell culture lipid defect. So at least it's not cell intrinsic. Cell cultures are not humans, but it doesn't appear that the human has any problem. Gram-negative bacteria are made out of phospholipids, and so they're overlapping with the disease. So I thought, all right, well, maybe atopic derm could be a gram-negative commensal problem. So this kind of pushed us into 2 ways. We can do 2 things with that. Number one, could the microbiome be a kind of canary in the coal mine? Could we use these bacteria to see, all right, if there's an exposure that's turning off those ceramide productions? That would be something we need to worry about. And then obviously the other one would be, could we use a ceramide-producing probiotic? So I'll just briefly talk about the probiotic one. So the first thing we did was start trying to figure out how to culture gram-negative organisms, and we could get various ones off, but for the most part, healthy people, about 70% or so, would have this one, like I said, Roseomonas mucosa. Even from the initial evaluation, you could just tell that the bacteria were stark, had a different phenotype just from the start. So this is Roseomonas taken from healthy people, and this is an example of one taken from a patient with atopic dermatitis. And even though by sequencing, these are near identical, we're not finding a whole lot of genetic differences between them, but you could put the healthy bacteria into mouse models, barrier function models. The healthy ones would all improve those models. The disease-associated Roseomonas would always make it worse. Healthy ones actually help kill off Staph aureus and so forth. The question before we start throwing live bacteria and gram-negative rods on children, we want to see, do we have to do this? Is there a way we can get around it? Could we make an extract? And the short version is no, that if you use in a mouse model, the live bacteria will do a good job. But if you killed Roseomonas or put it in a supernated, it didn't matter. We couldn't get anything to work. You needed the live organism. Important thing with the probiotic world is I think we skip over the safety part because we think, oh, it's a natural commensal organism, but remember you're hyper concentrating it, which now makes it an unnatural exposure. But that said, we took 10 to the 10th and put it into a mouse directly into the vein, and we cannot induce an infection. We can't kill anything. It just does not seem to have any virulence potential, which is important. Not so much true for some of the coag negative staph that people like to use for therapies. And then we put it in an open label phase for adults at this time with some pretty impressive results. So that we said, all right, fine, we're going to go to children now. So this is the open label. This is the EASY score as a measurement of rash. And we had 2 different dosing regimens. It didn't seem to matter. For the most part, people got about 75% better during the course of 4 weeks. But the part that we thought was really important is when you talk to patients, they do not want just a slightly better topical that they're committed to for the rest of their days. They want something that will alleviate their disease long term. So we brought people back 4 to 8 months later. And you can see that whatever improvement they had, they maintained up to 36 weeks, and then we stopped monitoring. And by PCR, we can actually look and find our exact treatment bacteria were still present. So this gives the people the option of colonization, which I always thought was the strongest argument against trying to come up with a bacterial extract formulation, because that's not going to last, whereas the colonization would. And so the way it works at NIH, some of these things get licensed out for placebo-controlled trials. And so the company ran a private company ran the phase 2. And for the most part, they had an overperformance of the placebo group for various reasons, which we won't get into. And they set their clinical endpoint appropriately at what the FDA would say was active treatment. And that was the only one that was not statistically significant. So that was kind of a commercial hit for them. But you'll notice that the second that they stop the drug, you see the placebo starts to wear off and we develop a significant effect. Now, this does mean that we have to repeat this trial, and we'll talk about that with a longer washout phase. But again, twice now, you give people treatment and you stop and the bacteria continues to work. All right, so now what about the air pollution part? So what we did is we accessed a database, kind of like the Aaron Brockovich concept. I want to find eczema hotspots. And if I can find those, I'm going to cross-reference that with the EPA databases to say what pollutants are elevated in those hotspots. And if there are any spatial statisticians in the room, forgive me for the imperfectness of this analogy, but this is the basic way you can split these up, is if we wanted to say what would predict home sale prices, 2 ways you could do it. A non-spatial model would overvalue the concept of neighborhood. So if you said what predicts somebody's house, well, house sales, the houses next to them, the schools, yards, and so forth, all those are neighborhood. The other one you might say, all right, I want to be independent of neighborhood because I want to answer the question, do I want to remodel my kitchen or my bathroom? Which one would be more valuable? So those are the 2 ways of doing it. One is more neighborhood focused, one is independent of that. So the independent one, the neighborhood focused one, this is we did this a lot of different mathematical models. I'm just showing you what would predict going to having an increased visit rate for atopic derm to pediatricians, okay? So number 1 is this thing called diisocyanate fugitive, which is actually better than pediatric allergy and immunology doctors. So if you wanted to increase the visit rate for atopic derm in your zip code, hiring Dr. Sharma to come there would be less impactful than one of these factories producing diisocyanates. And so you say, all right, what is that? So these are just basically aromatic compounds that have the isocyanate side chain. We also looked, they were statistically associated with peanut allergy and asthma, but not psoriasis. So it wasn't just a general skin inflammatory disease. We looked at autism and some other kind of pediatric illnesses as control. So it really did seem to be associated only with atopy. How would one expose yourself to diisocyanates? So at first they were invented in 1940 and started their manufacturing in the United States right about 1970, and it escalated since then. So TDI, toluene diisocyanate, is the most common one, is the most volatile. Living next to a highway, diisocyanates are now a product of gasoline only after the catalytic converter. If you light a bucket of gasoline on fire, you don't get any isocyanates. If it runs through a catalytic converter, you will. Catalytic converter is the reason all those other things are going down. So that's good. It was not choking us off for asthma from sulfur dioxide, but as a side product, it makes isocyanates. Catalytic converters became mandatory in 1975. There's one and only one natural source of isocyanates, and those are wildfires based off the particular foliage that might be burning. And then if you wanted to fill your house with isocyanates, you would use paint, polyurethane, memory foam, new furniture, floor wax, floor sealants. And then cigarette smoke would be a good way of doing it. So kind of this epidemiologic overview. So putting the bacteria up against these different chemicals to see what would happen. What you're looking at here is just photos of the bacterial colonies on a culture plate, either grown in ambient conditions or in the presence of TDI. And you can see we can kill off the healthy versions of Roseomonas. We can partially kill off the diseased ones, but they seem to be a little bit better adapted at this chemical. For staph epi, kind of a health-associated staph, you can see you get a partial killing from these chemicals, and Staph aureus is impervious to its toxic effects. So I don't have time and I don't want to belabor the chemistry here, but the short version is for Roseomonas, it's actually a nitrogen fixer. So it actually takes nitrogen out of the air along with carbon dioxide, and will take that and put that directly into phosphatidylcholines, which then become the ceramides. So these bacteria are making the beneficial lipids for you out of thin air versus the coag-negative staph, which again are helping the host. And this is kind of known from the occupational asthma world, how the isocyanates work. They tag on to the amine groups off the sides of phosphatidylcholine and downregulate those. So you can actually watch this happening. So in black is the growth. And so you can see at different levels of TDI, we can increase the growth. But the bacteria are metabolizing this away. And what they're doing is they're turning off their ceramide production as a means of surviving this toxin. And what they're doing instead is upregulating lysine, which is a trick that Staph aureus uses to protect itself against oxidative challenges as well. So it's flipping the physiology away from the beneficial lipids towards some things that are anti-protective for itself, but they're coming at the host's expense. And so we can go back actually to the clinical data to ask whether or not this had any real world implications. Now, the company had absolutely no way of knowing about this before we started, but they picked 15 different sites and 15 different zip codes. So now we can ask whether or not your pollution in your zip code predicted a difference in outcome. And indeed, if you were in a level, if you were in a zip code that had higher than average diisocyanates, you got significantly better than if it was below average. But you can see in both situations, the improvement was maintained, whereas the placebo started to wear off. And we interpret this as meaning that if you're in an environment that's already pristine, then replacing your skin microbiome may not be so as helpful as if you're in an environment where these things are being toxified consistently. Again, we're going to do this study over again and look prospectively at the different locations. So now, having educated ourselves on what it could do to your skin microbiome, we can actually go back and look at, is there any potentially direct effects on the host? Again, a lot of the isocyanate work was done from occupational asthma world. And one thing is known as TDI specifically activates this receptor called TRPA1. So TRPA1 is a thermoreceptor. It's supposed to pick up cold, but it's also activating in pain and itch. And so probably the most disturbing part when I was looking through to say, like, oh, what chemical is this going to be? And then you see disocyanate and you're like, what is that? Let me go Google what this is the fact that people actually intentionally use TDI as a mouse model for atopic derm. So you can induce directly atopic derm in a mouse by putting TDI on its ear. You'll see this big inflammation in its ear. If you take a TRPA1 knockout mouse, that's less so. So less of the direct effect on the host. And again, when you activate TRPA1, one of the neurologic signals that it sends most strongly is itch. So now we've got this chemical that's floating around that'll poison your microbiome and directly activate an itch receptor in the skin. But that's the isocyanate side. And then the other side of the equation was, all right, what happens when we do the independent of the neighborhood model? And TDI is still on that list, but now all of a sudden there's something called xylene that jumps up on there. And xylene is associated, kind of driven and collinear with these ethylbenzenes and 1,2,4-trimethylbenzene. You're like, all right, what is this guy talking about? But this is directly off of the Department of Energy's website putting these together. So they're related in the fact that there's TDI, there's xylene, here's our nylon and polyurethane and all this stuff, and polyester fibers. So BTX are anti-knock agents that went into gasoline. So the previous anti-knock agent is the world famous lead. Lead was pulled from our gasoline in 1975, and this was put in there as its replacement. And so this leads us to our hypothesis that you couldn't even go find a reusable water bottle with BPA right now, but it's just because it's a hormonal disruptor. It's not the only one, it's just the most famous one. And so there's a shared chemistry. And so what we think is happening is just like in the hormonal disruptors, there's a shared chemistry that gives it a shared harm in the body, but that shared chemistry gives it a shared utility for industry. They're almost always made into plastics. So things that the BTX chemicals, these are going to be sealants and paints and foams and so forth, and anti-knock agents in your gasoline. And so when I present this normally to patients, the first question is, oh my God, this is overwhelming. What am I supposed to do? How am I supposed to avoid any of these things? And so we tried to prioritize them a bit. So what we did was this is a survey question. So you see the eczema patients over here, the controls, and mapped by severity. And so, yeah, you can see the co-occurrence of all the other allergic diseases are more likely, but we put these together to say like, all right, well, what do you guys, what should we really be concerned about? And you can calculate two different ways. The risk, relative risk ratios has wallpaper and hardwood floors in childhood would be the most impactful. Technically, these were infinite, but those would be the worst things you could do. And you can also say what was the most predictive, and again, wallpaper and carpet are here, but polyester. And so you say, all right, let's go play with bacteria and polyester and see what would happen. And what we do here is we took different fabrics and we sprayed them with an equivalent amount of bacteria. And then we just set the fabrics aside to see how long the bacteria would be able to survive only on the fabric. And so this is Staph aureus over here. And so these are all got the exact same bacteria at the start. And you can see it proliferates quite nicely on nylon and won't survive more than a couple of days on bamboo and cotton. Over here, you've got Roseamonas, which seems to grow actually fairly nicely consistently. And you might think, oh, that's not too bad then polyester would have Roseamonas on it. Yeah, bad news that the physiology, again, is being manipulated in the healthy bacteria. It's no longer as beneficial as you'd like to think. So we could say that certain fabric choices would harbor the negative bacteria. And I think this would be concerning for patients who have an active flare coated in Staph aureus, climb into the bed sheets, seed the bed with Staph aureus, and now that's going to sit there for multiple days. So really what we need, I think, arguing more than anything, is we need a system that can look at all these different exposures at once. We got to be able to track the different chemicals in real time, more than just air quality index, which is just those few things that come out of the back of the car exhaust that I told you have been going down. And we can do, with that, we'd like to do three different things. The first is connect it with the eczema tracker. These kind of real-time patients telling you whether they're flaring to see if there's a flare in the surrounding community. We'd really need to vet some kind of air filtration systems, because some of this stuff is just going to be unavoidable for patients. So if you had a air filter that genuinely could pull this stuff out of the air, that would be great. And then go through and say which of these particular home exposures are truly the most heinous. Is there a version? Is there brands that are better than others, and so forth? And so this is, I'd like to put all of this into one big slide with everything there. But the point is that everything in red, I can provide you with a molecular mechanism why it would be connected to atopic derm directly through the microbiome. Everything in blue is mathematically associated, but doesn't yet have a molecular mechanism. So while we're planning to get this stuff out of the environment, we are going to start a new trial with topical Roseamonas and anti-TRPA1 to kind of provide that additional itch benefit. I suspect children sees plenty of people, so there's no excuse not to send us some referrals. And this is who you would contact to get the patient set up. And it is going to be fully virtual to kind of alleviate some of the transit burden. Thank you.
All right, thank you so much, Dr. Myles, for that fascinating presentation. Now you know why I called you esteemed.